Bom dia. So the sound is okay. So good morning. Thank you for coming. And it is our pleasure to welcome Professor Costantino Pitzalis. This will be a co-chaired welcome, as Professor Costantino Pitzalis, for some of you, for others no, is someone that you know quite well, because Professor Costantino Pitzalis has reminded us that has a collaboration with us for 15 years. So time goes by very quickly. And it was almost like yesterday that we started to have the pleasure of having Costantino Pitzalis with us. He is working at Queen Mary University of London. This is one of the steps of Professor Costantino Pitzalis. The other step is at a very special new university, relatively new, in the north of Italy, in Milan, called Humanitas. Some of you know it. It has been growing steadily and has delegated part of the investment in research to Professor Costantino Pitzalis. This was also a way of giving back to his own country the achievements that he did over his long career. So to give us a few more details, Joaquin will also comment on this talk and the relationship that we have. And thank you for coming.
Thank you. It's always difficult to compliment Professor's words, but in fact, Professor Pitzalis has been very important in this long collaboration we have. He's been at the forefront of the personalized medicine. At least we are trying to have personalized medicine in rheumatoid arthritis. We still cannot do it in our clinical practice, but hopefully we will, and we are talking on that. And in fact, he led two of the major biopsy-driven trials, Arthritis and Strep, that we were lucky enough to participate, and that also allowed us to leverage our synovial biopsy to another level and to develop, for instance, the PhDs of Vasco, which is supervised, and also my own PhD. So it's for us very important to have him here again, and hopefully again in the future. And it's your time now to show us the world of personalized medicine in RA.
Thank you. Real pleasure to be here, and it's like coming home every time, because there is a personal friendship which has been built over many years. And so there is a real emotional feeling of coming back. And so thank you for coming today. What I'll try to do in the next 40 minutes or so is to take you through the advances that we made in the last 15 years. So there is a lot of data, but I will try to give you examples, particularly how we can really transfer the information from a deep molecular phenotyping of the synovial tissue into clinical practice. Where we want to get one day is really to do towards personalized medicine. And so this is the university in London where I work, and this is the Charterhouse Square. My laboratory is on the second floor of this building. That's where Vasco came, Rita came, and many others of here, the University of Lisbon. And these are the hospitals where we work. There are a number of major hospitals in London, including the trauma center with a helipad on top. So it's really important. And this is a Humanitas University for the last 4 years I've been working on. So I think having changed the microphone, I think I need to change sides to talk on that side. So it's probably better here. Was okay? So
Yeah.
Either side, yeah. Okay.
Just a comment. I think that the camera will pick you just on the other side. Oh, okay. So speak on the side.
Okay. In that case, I stay here. And so I'm not sure how many of you are rheumatologists, how many internal medicine doctors. So
Yes.
okay. So for the rheumatologist, then there is no need for me to say that rheumatoid arthritis is a chronic inflammatory arthritis. For the students, it's a really important disease, and the hallmark of the disease is the inflammation of the lining of the joint, which is called synovium, and then which really erodes the cartilage and the bone, the subchondral bone, and that is the marginal erosions that you can see here. And there are two important things to say from the images that you see here. Is a symmetrical synovitis, which affects the metacarpophalangeal joints and the proximal interphalangeal joints, which can be destructive in very, very short time, in the very aggressive form. So that's why there is a need to treat early and prevent the damage. Also, you can see that these patients on the left here is very different from the patients on the right. One has got a mild disease and one has got an aggressive disease. And understanding the difference and what leads to this is really critical part of what we are trying to do. It affects 1% of the population and it's got a huge health economic burden. And if you read any textbook, you say the pathogenesis of the disease is what you see here. So in genetically predisposed individuals, exposed to environmental factors, which could be bacteria or smoking, for example, you enter into a preclinical phase, the systemic autoimmunity phase, in which practically you get a reaction, an immunological reaction to antigens, which can be multiple antigens, which we do not know. But essentially, you get the classical antigen presentation, activation of T and B cells, which leads to the autoantibody production, which is the rheumatoid factor and the anti-CCP antibodies, which are circulating and are present in 70% of patients. Now, what happens from the systemic autoimmunity phase to the symptoms is not really known, but essentially there is a second hit which transfers the joint from the systemic autoimmunity to the joint itself. And there, essentially, you reproduce this immunological reaction. And although this is true for most patients, it's not true for all patients. And that's why it is really important to distinguish the heterogeneity that I will show you at level of the tissue levels. So this, nonetheless, this immunological reaction and the understanding of the pathogenesis leads to the production of pro-inflammatory cytokines, which then lead to the activation of osteoclasts and the damage of the joints that you see here. So this has led to the development of common use now, but 20 years ago, this thing didn't exist, or 30 years ago, this thing didn't exist, of monoclonal antibody therapies against the various components of the immune system. So you have here anti-cytokine antibodies, particularly anti-TNF, then you have anti-IL-6 antibodies, anti-B cell antibodies, and anti-co-stimulatory molecules antibodies, which are part of the common practice. So this is now the general understanding for the students. So why do we need then personalized therapy if we have all these drugs which have transformed the life of many patients with rheumatoid arthritis? Well, the first reason is illustrated here. We are unable to predict which patient is likely to respond to which drug. So what we do in clinical practice, we start synthetic DMARDs first, then we move to anti-TNF therapies, and then subsequently move to other biologic therapies. But we do it on a trial and error basis. We don't know whether the patient is going to respond or not to respond to this drug. Also, very importantly, there is still a major unmet need. Approximately 10 to 20% of patients do not respond to any of the medications that we have available. The so-called difficult to treat patients, but also patients who are really multi-drug resistant. And we have a program that the University of Lisbon is part of, and Joachim is actually leading for the university, is the PI for the University of Lisbon, that we are very proud of having you on board. So the other reason that we need personalized therapies is that not only we cannot predict which patient is going to respond to not respond, but we know that there is a progressive increasing risk of failure. If you don't respond, if you start on synthetic DMARDs, you know that at 12 months, 40% will not have responded. But if you don't respond to anti-TNF therapies, this increases and gradually you get to this refractory state. This is obviously associated with this severe risk and decrease of quality of life and toxicity and disability. But what's important is we still don't understand what leads to the state of refractoriness, whether we are dealing with a disease endotype. It's not moving. Oh, here it is now. So in other words, you have a bad disease at the beginning, and then it doesn't matter how you treat it, you end up with the refractory state. Or whether the refractory state is the result of the fact that we expose in patients to one drug after the other, which really modifies the pathology. And therefore, it could be, for example, if you don't respond to anti-TNF therapy, that you develop alternative pathways, which then the patient becomes resistant to anti-TNF. And thereby we modify the disease as we progress. And we call this drug-related endotype. So we need to resolve the heterogeneity of the disease, both at the clinical level to avoid this exposure of repetitive drugs, which currently, as I say, only approximately half of the patients respond to the first drug exposure and the other half doesn't respond. And we have to move from one size fits all approach to personalized treatments to prevent the development of refractory RA. So we need biomarkers to do this. However, when we look at the peripheral blood biomarkers for the last 30 years, essentially, this can sometimes go too fast. Okay. This is a meta-analysis of 57 eligible studies, which demonstrates that none of the peripheral blood biomarkers can predict treatment response. What we can do with the peripheral blood biomarkers is predict and assess the disease activity state. So we know that the CRP is very strongly associated with disease activity and can also, in a sense, tell you that probably this patient will respond better, but I cannot tell you which drug they respond to. And it is important to understand that the disease is heterogeneous not only from the clinical point of view, but for the pathobiology point of view. So this is again for the student. This is a normal synovium here. You can see that there is a really very thin layer in this lax connective tissue with very few infiltrating cells. Now, who are the students? Can you raise your hands, the students? Okay, that's great. So then pay attention to what you see here, because this is the classical histopathological features of rheumatoid arthritis. There is hypertrophy of the lining layer, and you can see how many cells are infiltrating here. All this dark staining are new cells which are infiltrating. These are mononuclear cells coming from the periphery, surrounding blood vessels. Here you can see this form, this perivascular cuffs of infiltrating cells. And in some cases, they form these follicle-like structures, which many years ago, over 20 years ago, we demonstrated be similar to what you see in a human tonsil. So these are the secondary lymphoid organs, and you have the full structure of follicular lymph node. However, from a study that we published in 2013, we reported for the first time, when we look at the distribution of these structures, they are not present in all patients. So you can see from this image here that is present, we call lymphoid pathotype, in approximately 40% of patients. But in other 40% of patients, you got this myeloid pathotype, in which you got lots of macrophages, CD68 positive macrophages, but very few B cells. So the third subset we describe is the post-immune or fibroid pathotype, in which, again, you have very few immune cells, but you still got an hypertrophy of the lining layer. So the concept, for example, that the pathogenesis scheme, which is applied to every patient, is actually not true. Because in these patients, the inflammation is not driven by the immune reaction. but is driven by a stromal reaction. So if you give, and I will show you the data, the immune modulatory drugs to these patients, they are less likely to respond to other type of drugs. So this is the first concept for you to take home, that probably the expression of the target in the disease tissue is determining whether the patient is likely to respond or not respond, and therefore personalizing treatment. So we hypothesized on this basis that if we could take a synovial biopsy from every patient, then we could really do a molecular profile which is individualized for patient 1, 2, or 3. We could look at the target expression level, for example, of B cells, TNF, CD80, CD86, or IL-6, and really personalize the treatment and resolve this diversity of treatment, of patients' heterogeneity, but also treatment response. So we then developed a synovial biopsy procedure, ultrasound guided, and we trained over 50 centers in Europe, and now the Lisbon Center is well established as one of the major training centers and can participate. You can see that you got high quality tissue from the majority of patients, high quality RNA for the molecular profiles, and this well tolerated by patients. It's also a safe procedure, as thousands of patients now and publications have been demonstrated, and it's been now endorsed by EULAR with multiple courses. So Joachim, if you want to run one of the EULAR courses, for example, can also be done here. So in addition to the histopathological profile, which I've already described to you in 2013, also there is a molecular profile which goes with these pathotypes. And this is important. And this is important also from the therapy point of view, because as we said already, why do we give rituximab, for example, to patients who don't have B cells, or the fibroid patients? Again, there are no immune cells. So these patients, in fact, are the resistant population that really becomes even early in early arthritis. And I will show you the data for that. So we also developed this integrated pathobiological program to really try to dissect the different stages of the disease. And these are the trials that Joachim was alluding to, the STRAP and therefore array trials. But also we start with the early arthritis trial, which was called PEAK. And this now, all these trials have been published. The references are here. If you want to take a picture, you can take a picture, and if you want to read about these papers. But essentially what we did was to stratify the patients according to the stage of the disease, early, established, difficult to treat, and now refractory in the last program that I will describe to you in detail. And every patient was also stratified for treatment exposure, for the concept which I mentioned to you, that if you treat patients with powerful biologic therapies, you might modify the pathology. So if you're comparing patients treated with different drugs, you might end up with the wrong answers. So it's stratified for stage of the disease, but also for treatment exposure. So the PEAK patients, the early arthritis patients, are all treatment naive. They are biopsy and they started on therapies. The STRAP patients, synthetic DMARDs, inadequate responders, but biologic naive, biopsy and then randomized to rituximab, tocilizumab, or anti-TNF therapies. Therefore, array trial, these were patients more difficult to treat, and they were non-responsive to anti-TNF therapies, and then they were randomized to rituximab and tocilizumab. And in the refractory patients, I will tell you a little bit more details later on. So in every patient, we did the molecular characterization and the histopathological characterization. Now, you cannot do these trials if you don't have the support of your colleagues. And this is now for the array consortium, in which you can see the picture of Joao, but we need to substitute the picture with Joachim here, because Joachim is doing all the work. So I think, Joao, we are extremely grateful, and I'm sure everyone in the audience, for your support and really vision of creating such a unit, which now you've got so many talented young faculty that really can take it forward. But these are all the participating centers, 23 European centers participating in our 4RA. And you should be proud that the University of Lisbon is part of this elite group of top European centers that are delivering these trials. So, but what do we learn from this biopsy development, and what is the clinical relevance? I understand that most of you are clinicians, and therefore it is important. Can we use this information to really guide our treatment? So I'll very briefly, because this is all published, as I say, I will go through, these are some of the references, and this is an opportunity for me to thank the people who work with me on these trials in London. So what we learn, the first thing that we learn is that when we look at the patients with early arthritis, we also see these three pathotypes, the post-immune, the diffuse myeloid, and the lymphomyeloid with these follicle-like structures. And this is now the first RNA-seq, which was published in Cell Reports in 2019 of the Synovial, which again demonstrates how you have these pathotypes early in the disease process. So what is it telling you this? It is not just the drugs modifying the pathology, but the pathology is present at the beginning. So you got different treatment. Do we personalize the treatment at the beginning? No. We give methotrexate to everyone, which is probably not what we want to do, because we would predict that the methotrexate will respond well with these patients, but not so well with this patient, because it's an immunomodulatory drug, it's a cytotoxic drug, so there is no immune cells here to modulate. So what we learn also is that we can redefine the disease classification and diagnosis and prognosis. The lymphomyeloid patients, for example, are those associated with worse disease at 12 months. And also these are the patients we can predict at the beginning, which requires biologic therapy at 12 months. So with molecular signatures. So why wait 12 months to start the biologic therapy in some patients that we know they are not going to respond, and we know that 40% are not going to respond, and 12 months is a long time of suffering for a patient. So we need to use this information, and we will, to transform the way in which now the guidelines are structured. We also, importantly, we can dissect the pathogenesis. And this is a fundamental work which was done in collaboration with the Accelerated Medicine Partnership in the USA, funded by the NIH and industry, in which the biopsy this time was digested and single cells were eluted, and then done single cell RNA-seq and other modalities, which led to the publication in Nature Immunology and Nature, which now they form the basis for any type of single cell work in rheumatoid arthritis. So you can go to the websites and download the single cell profiles and then compare them to your own analysis. So essentially that's what we've done. This is the methodology there. And this has led to the development of the understanding and the description of 18 new cell states. So not only B cell, T cell, macrophages, and fibroblasts, but within these four categories, there are additional molecular profiles which distinguish different subsets with different functions. So this has led to a incredible number of publications, which again, I'm not going to go through in details, but I'm going to give you some examples of the clinical relevance of this single cell analysis at the T and B cell level, at the macrophage level, and recently at the fibroblast level. So this fibroid pathotype is really important, and there's been a number of publications. And for example, this is, don't worry about reading all the details, but the Harvard group published this seminal work, which has demonstrated the T peripheral helper cells, dry B cells activation in the joint. So again, for the immunologists in the audience, in the lymph nodes, you have cold cells which are called follicular helper cells, which prime the B cells to produce antibodies. Now, there are very few follicular helper cells in the synovium where you have these follicle-like structures because it's full of T peripheral helper cells. And the difference is that in the follicular helper cells, it's a PD-1 positive, ICOS positive, but also CXCR5 positive, whereas the peripheral helper cells are CXCR5 negative. Again, this is going a little bit erratic, this pointer. Oh, is towards the computer. Okay, now I understand then. Okay, so this is for the T cells. This is for the B cells, in which the specific age-related B cells in the synovium, which express this orphan nuclear receptor and are for A1 and 3, really drive the formation of this follicle. So in some patients, we have B cells, so we can distinguish a B cell-driven synovitis. And in some patients, we have very few B cells, the fibroid and the lymphomyeloid patients. Now, this is now the diversity and the clinical implication for the macrophages. So this heparin-binding epidermal growth factor positive macrophages are the pro-inflammatory macrophages, which activate the fibroblasts and lead to the destruction of the joint. Whereas, for example, the METK positive fibroblasts, this is work now from Stefano Livernini in Rome, that demonstrates that the METK positive fibroblasts are expressed in patients in remission. So no patient, now these are the opposite subset of the one that I showed you before. And as you can see here, these are the patients in remission up here, and there is an expansion of this subset in this FACS profile. Whereas the METK negative, SPP1 positive, S100 positive macrophages are linked to the active disease. So I think really now we have the handling of understanding that the macrophages, different subsets of macrophages, are associated on the clinical level with remission or response or inflammation. And a score that they develop, a low proportion of METK, which are the anti-inflammatory cells, is associated with an increased risk of disease flare. So it's got clinical implications. For the fibroblasts, the same thing. We have now a real understanding of multiple types of fibroblasts. The CD90 Thy1 negative fibroblasts in the lining layer, these purple fibroblasts here, are those associated with the bone and cartilage destruction. Whereas the CD90 positive, Thy1 positive, are those subsets of macrophages that drive inflammation in the synovium. And we have demonstrated that the DKK1 positive macrophages are associated with refractoriness, and I will show you some more data about this. However, there is a description by the Erlangen group that shows that the CD200 fibroblast positive form these pro-resolving mesenchymal niches. So it's possible that we can really modulate both the T and B cells, the macrophages, and the fibroblasts in these diverse type of patients to really then treat patients in a personalized approach. And the fibroid pathotype is really important for refractoriness. So because we don't do biopsy in every patient, we do not know what the patient is likely to respond. However, we know that even in early arthritis, the fibroid pathotypes, 70% of patients do not respond to either synthetic DMARDs, and when you expose them to anti-TNF therapy, also they do not respond to anti-TNF therapy. So it's a real important pathotype from the point of view of response to current medications. We demonstrated this in an independent cohort. You can see this is an established disease now, and the post-immune synovial pathotype predicts inadequate response to a TNF blockade. Again, here only 23% of patients respond, and 71% do not respond to anti-TNF therapy if you have a fibroid pathotype. And in the R4RA trial, in the true refractory patients, we did not respond to IV rituximab or tocilizumab. With a switch over, they were really, these 32 patients did not respond to any drugs. We identify specific synovial signatures. These are again the molecular signatures of patients with refractory disease, which have a very high strong signal for markers associated with the fibroblast, including the FGF receptor and so on. But we also demonstrated using the convolution techniques that this is the DKK3, as I mentioned earlier in this paper, that is the subset specifically linked to refractoriness, which was also demonstrating using digital spatial profiling, which represent the new frontier. So we can now determine the cell state, this new cell state described by the Accelerated Medicine Partnership, actually in space in the biopsies, because the new technologies enable us to have a transcriptomic, a proteomic profile within the synovial tissue. So this is going to be transforming everything we do, because these are synovial tissue biopsies, which are included in paraffin. So the normal pathological specimens now can be used for advanced molecular profiling. And this is some examples, again, coming from Harvard University. This is a slide which demonstrates the segmentation that we can do at each individual level, and then really define in an unprecedented way the molecular characteristics. So, but what's really important for clinicians is whether we can predict treatment response prior to giving the drug. So currently we give them blindly, and could we do a biopsy in patients and then choose which drug? So I'm going to very briefly summarize, because again, I published our collaboration with the University of Lisbon. You participate in the STRAP and R4RA trial, in which we were already published, which aim to define the molecular signature predicted treatment response. STRAP and R4RA were analyzed in two ways. The first way was using conventional histology. So, and the patients were defined as B-cell poor and B-cell rich according to a semi-quantitative score of CD20 immunohistochemistry, which clearly is a one marker, or we could use it a molecular pathology classification in which we use the target expression level of 70 genes or so associated with B cells. This is important because when we use the histopathological classification, both trials don't meet the primary endpoint. So you will hear a lot of speakers saying, well, the molecular pathology really is not that helpful because the trials did not meet the primary endpoint. However, I'd like to point out that that is correct. We did not meet the primary endpoint. There was no difference between tocilizumab, which was the control drug, compared with rituximab in the primary endpoint, which was CDAI 50. But when we look at the patients in low disease activity, twice as many patients in the B-cell poor population, in other words, with a fibroid or lymphoid pathotype, responded to tocilizumab compared with rituximab. But the trial really was massive, informative when we do the molecular characterization. Here we both meet the primary endpoint, and also when we look at the disease activity, the low disease activity patients, you can see that only 12% of patients actually responded to rituximab, which means that in 88% of cases that we give rituximab, the patients don't reach low disease activity. Is that what we want for our patients? Is that what we would do for our sister or our brother if we knew that this patient, that our brother or sister was a B-cell poor patient? Would we give rituximab to this patient? We wouldn't. So I think there is real momentum growing, although still we cannot do it as a sort of indication, but it's very informative. But what really was informative then there was a deep molecular RNA sequencing analysis of these trials, and this is the trial analysis for rituximab for array, and you can see that we can really distinguish signatures for responders and non-responders, both for tocilizumab and rituximab. We done the same for strap, and then what we did was to use molecular predicting using machine learning technologies, which then develop a predictive model which clusterizing genes can tell us which patients are likely to respond and non-response with a relatively good accuracy. In 70% of patients can predict which drug they're likely to respond. These signatures were then validated back into the independent cohorts of our 4-array with, again, very similar predictive value. But important then, can we translate this into clinical practice? Because, again, you can't use RNA sequencing for making a clinical decision. So what we did was to really develop a digital barcoding technology, which is called nanostring. We took out approximately 500 genes from the whole transcriptome of the RNA sequencing, which were strongly associated with treatment response. And then you can use this to really define in a molecular characterization, which takes 5 working days. Essentially, that's what we are using in the trials, which I will describe to you in a second. And you can define the molecular patterns. And this is an example of such a patient in which you see this is the expression of IL-6, and this is the expression of TNF. Each row is a patient. And you can see we have a cluster of patients here. These are the fibroid patients primarily, in which the level of IL-6 and TNF are very low. These patients here, they got high level of TNF by low level of IL-6, and vice versa, these patients. And there is a group of patients here that express both pathways. And what that means is that essentially, these are probably the responsive population that we see the 50% of patients that it doesn't matter which drug we give, they will respond. And so that's what we do in clinical practice. However, what we need to do is really to develop drugs for these patients who do not respond. So using these panels, these 500 gene panels, then we took the RNA, which was left from the strap trial. We do the molecular profile and predicted which treatment response was likely to happen and compared this to the observed response, the real response in the trial. And that is shown here. If this thing moves, okay, I move too fast. Okay, so this is the predicted response for etanercept. So we predicted that the algorithm predicted that 23 patients would have responded to TNF, and the actual response was 19. For tocilizumab, the prediction was that of 26 patients would have responded, and 23 actually responded in the trial. So there is a very high predictive value of the panels, the nanostring panels compared with the trial. And for rituximab, of the 12 predicted to respond, 11 actually respond. So you really have a tool now that you can use in clinical practice with an accuracy between 82 and 87%. And that's why we developed this algorithm that we published in Nature Communication last year, which now is informing the randomized clinical trials that we are going on, which are called Precise Theta and Partner Array, which are just starting here, the Partner Array in Lisbon. So can these panels inform actually treatment decision in practice? These are part of the 3TR program, these 2 trials. And this is a very busy slide, and apologize for that, but I'll take you through very briefly. So from the strap and array trial that we took so far, we identified specific signatures. So we call them biomarker discovery trials. So then we can develop predictive model we can do a nanostring analysis in 5 working days. And following a synovial biopsy in the Personalised theta trial, which is a patient with established disease, we can establish whether the patients are higher expression of TNF or higher expression of IL-6. And we call these biomarker positive patients. And these patients will be allocated the equivalent drug, either sarilumab or etanercept. If they are biomarker negative, the patient will be randomized to these 2 drugs. So every patient gets the drug, which is important from the ethical point of view. So the patients that you like to refer to the Personalised theta trials will receive either sarilumab or etanercept, regardless, in a sense. But the analysis will be done based on the biomarker status and the biomarker positive and negative status. Also, we have a control population, which the patient will be randomized to these 2 drugs independently of the biopsy result. And that's the control group. In the early arthritis group, again, patients naive to any treatment will have the fortune, and this is really when you encourage your patient to participate in a trial, they are not doing a favor to you, but you are doing a favor to the patient, because 50% of these patients will not respond to conventional DMARDs. But in this case, they will be randomized to either methotrexate, which is standard of care, or abatacept, which is a drug which has been shown to work very effectively in patients with early arthritis, or they will be randomized to methotrexate plus placebo. So again, every patient will receive standard of care, but half of your patients will have the fortune of receiving abatacept, which currently you cannot give it to them because of the regulations. So this is a very important early arthritis trial, which we believe we transform in the biomarker positive patients, the outcome potentially inducing remission. These are the sites which participate in the trial, and we recruited for the Personalised theta 151 patients already out of the 200. So we got 49 patients to go, and I think Lisbon has got probably 7 or 8 patients to reach the target of 20 patients. In the in the partner array, which is the early arthritis trial, we have only 6 sites open at the moment. Here we had 15. We are going to open them all very quickly, and we got 15 patients already randomized. So again, these are two trials that will help you as doctors to really, and the patients that you see, to receive innovative therapies, because they will be receiving drugs that you will get anyway, but here with the molecular profile will be informative of which drugs they are likely to respond or not. So the last thing that I'd like to talk to you about, and I think probably I can do in the next 5 minutes, is the MDRRA program. Now, I define this, I'm sorry, I forgot to say, didn't want to be a lecture of you listening. If you have any questions at any stage, please raise your hand, and I'm very happy to interrupt and continue. But if we can continue for the moment now in this latest program, which is funded by the European Commission, in the Horizon program, in the MDRRA, the multi-drug resistant patient, because these are patients that you all have in your clinics. These are patients that have not responded to 2, 3, 4, or 5 medications. So what do you do with these patients? You just decide randomly, by chance, yeah, we will restart anti-TNF or we start steroids. It's really problematic patients. This program will help to dissect exactly what is the most likely chance of patients responded, or whether we need to institute alternative treatments, for example. We know that MDRRA patients, the patients so-called difficult to treat according to the EULAR definition, they are not just a homogeneous category of patients. They are very heterogeneous. And in addition to have potentially very active synovitis, some of these patients got very low level of synovitis, but they have a high level of chronic pain. So you can't treat the patients in the same way or escalate biologics in patients with low level of synovitis, but high level of pain. You really need to control the pain. So likewise, we need to do better than the EULA definition, because the EULA definition for difficult to treat is clear for criteria number 1, failure of 2 biologic DMARDs with active disease. So evidence criteria number 2 of progressive and active disease. But criteria number 3 is very vague. In other words, the management is perceived as problematic by either the physician, so you think that the patient is not doing well, or the patient doesn't feel this is doing well. What does it mean? We need to have more precise definition of these patients. So in the MDR-array, in the stage 1 of this program, we are going to do deep clinical and imaging models. So we are developing classifiers using the conventional disease activity management assessment, so the DAS28, for example, but also we are linking to ultrasound for evidence of synovitis, but also quantitative sensory testing for the centers that can do it, because we have patients with chronic pain syndrome with an increased sensitivity to pain. So we can measure that as well to define the clinical classifiers. Then we are linking that to the molecular classifiers. All patients will have a biopsy, so we can really then define which cytokines and which pathways are still active. And we do this with a detailed histopathological characterization, but also bulk RNA sequencing and digital spatial profiling, which is now the new way of doing this. Then using advanced predictive models of the type that I described, using machine learning, for example, we can then assess the question of whether those refractory molecular signatures are present at the beginning of the disease, because we have over 2,500 patients in the consortium with existing MDR-array, and these are patients who have been biopsied, part of the program which I described, so that we can really test in these patients whether, as mentioned, the molecular signatures are present at the beginning or they are emerging from the exposure to other treatments. So the concept, are we dealing with a endotype, disease endotype at the beginning, or this is pharmacological induced? So then we are going to put this integrated clinical, and I stress clinical and molecular phenotyping, because that's what they do in oncology. In oncology, they don't just make the biopsy, don't make the diagnosis, of breast cancer. You wouldn't dream of starting treatment with tamoxifen if you didn't know whether the patient was estrogen receptor positive or negative. You wouldn't give Herceptin to patients if you don't know the status. So why in rheumatoid are we going to give drugs in a blinded way when we have the tools to be able to really define the molecular characterization? So we are going to develop this integrated care model, which then will guide clinicians into a decision-making tool. This is a slide that Loreto Carmona from Madrid made for the application of MDR-array, but essentially integrates all the data that is available in the iCare model to guide clinicians on what choice they have in managing the patients. And these include existing guidelines, available measures, the clinical and molecular phenotype of the MDR-array program, but also integrating the multimodal AI-driven algorithm, including imaging, for example, which then will serve in creating this model. In the second part of the program, then we'll test this iCare model in a prospective cluster randomized patients in the various units. So that's why it is important, Joaquin and all the team in Lisbon, that we sought out the possibility of starting this prospective study as soon as possible, because on month 30 in the program, we have to develop the iCare model, which then will be tested in the second part. So I hope with this talk that we're coming to an end. You've seen that the molecular profile can really be helpful in the clinical decision-making, or at least informative. We are not there yet to the level of being able to do a test for every patient, and then you can do then order the test in the clinic and then get the results 5 days later and practice. But in the trials, you can do that. So I will encourage you to work very closely with your leaders and really offer the patient the opportunity to really to be treated better, because once they enter in the trial, obviously you look after this patient much better. So we have the molecular profile, which then will enable really hopefully to give the right drug to the right patient, because we have dissected the heterogeneity of the disease. Now, this is now the acknowledgements part, which is probably the most important part of my talk, because the first thing that we need to do is to acknowledge the patients. And this is the slide that the patients made for the application in MDR-array, the multi-drug resistant trial. So they are involved in every web package. There are 8 web packages. They are involved in all of them. And so involving the patient is fundamentally what we want to do. A great importance is the investigators participating in these trials. So again, I'd like to acknowledge the contribution of the investigators here in Lisbon, that together with the rest of the investigators are contributing to the delivery of these important trials. And finally, I'd like to thank all my team in London, the other investigators in PIC, STRAP, and for array that I described, the many universities contributing, as well as you for your kind attention. Thank you very much. I'm happy to take questions.
Very much. We'll have questions for sure. While people are thinking on the questions, and as you know, I will have to leave before the end of the discussion. I'm very sorry for that. But while I was attending your talk, I was thinking on something that I heard yesterday in the World Congress of Myositis here in Lisbon. I was moderating a session. Very interesting session on the story of autoantibodies in myositis. And it's a very long story for those that are not aware of that, and I was not perfectly aware of all the details. In fact, it started in the 70s. And bit by bit, we had autoantibodies that were a little bit like something that was appearing, but difficult to engage with the clinical practice. And nowadays, when we think on myositis, we do have an input from autoantibodies. It took time, but we do. Of course, having autoantibodies circulating is different from making a biopsy, although in that disease, biopsy is normal. Yeah, but here we have a story that might lead us to have biopsies as something useful in a phase where patients are willing to be biopsied in a way. So when you get a diagnosis, or when you are fighting to get a positive effect of the drugs, you are in fact willing to take more invasive diagnostic techniques. And this comes across all diseases. So any chronic condition where you're starting to have the diagnosis, you are open to everything that you offer. So this is something that we have also to sort out, because psychologically speaking, among rheumatologists, still there is a kind of a resistance against biopsies. Of course, we have to offer them quality results. But I do believe that combining these two comments that I'm doing, I have the impression that we'll get to a point where biopsies will be without any doubt of use, at least for part of the patients, other those that don't respond, or in an early phase to better orient them. It's my feeling. Discuss that.
see no difference. We are not. Fighting for the should be. We have to ask